Hello, everyone, and welcome back to In Plain English, the podcast where we make science approachable, open source, and jargon-free. I'm your host, Jamie Moffa, and today we are continuing with part 2 of our Interviews in Pain Research, a series of interviews that I conducted at the United States Association for the Study of Pain conference last month in Seattle, Washington. Today we're going to hear from 3 excellent presenters whose studies focused on the more clinical side of pain research. So without further ado, let's get started. So can you first start by introducing yourself?
Yeah, so my name is Ashley Bocanegra. I go by Chachi. I am a first-year student at the Indiana University, Indianapolis.
Cool. PhD student?
PhD student in the clinical psych program.
Cool. Very awesome. And yeah, so what is your research about?
So my research is, as we know, pain and sleep are highly correlated. We see that pain can exacerbate sleep outcomes. The literature has already supported that. But my research is really just looking at how does injustice interplay in the relationship between pain and sleep.
Okay.
And does do these feelings of this is not just, this isn't right, affect overall sleep outcomes, particularly in pediatric and children populations.
Right.
So we did a sample of almost 250 pediatric patients in an outpatient pain clinic and found that, yes, injustice does mediate the relationship between pain and sleep, and maybe this can help address overall treatment outcomes for sleep by maybe targeting some treatment-resistant patients and maybe seeing okay, maybe injustice is an interplay in this relationship, and we can address that.
So how did you assay injustice? What was the approach?
So for injustice, we used the IEQ as our measure. However, most of these questions are this is how do you feel feelings of this isn't fair, this shouldn't be happening to me right now, why is this happening to me right now? So it kind of measure or loads on questions of
depression
and anxiety.
Right. I was going to say this kind of overlaps. So have you looked at those as sort of independent variables? Or?
No, I think that would be the next direction, just because as we see that injustice does mediate this relationship, I think injustice is a more narrow focus of depression and anxiety.
Right.
And it's more looking at these particular set of questions, more so the overall broad aspect of depression and anxiety.
Yeah.
So I think that'd be the next direction for sure.
Yeah. I was also going to say because I just talked to somebody who was doing research on pain catastrophizing. So how is thoughts of pain and justice different from catastrophizing?
I think pain catastrophizing is more so the downward spiral of ongoing thoughts, where injustice can be an overarching thought of this should not be happening to me, but maybe not so much the constant rumination in these thoughts.
Gotcha. It just kind of crops up this isn't fair.
Yeah.
But it's not, continuing to get worse and worse and worse.
For sure. Yeah. So I think that although they have a lot of overlap, they can be differentiated in that aspect. For sure.
And so how do you for treatment-resistant populations, like you said, what do you think some of those interventions would be that would help sort of address the issue of the mediating factor of injustice?
Yeah, so I think treatments such as ACT or treatments that can be more so of acceptance-based model might be particularly helpful in somebody that you see high levels of perceived injustice, and maybe you wouldn't consider ACT as a treatment until you saw some measures of they're loading a lot on injustice, maybe that this might be helpful for this particular patient or client.
And so ACT is acceptance commitment therapy?
Yes.
Okay. And so that's sort of, just to explain it for the audience.
Yeah, acceptance commitment based therapy. So really going in and dissecting and really thinking on your own, why should I accept these? How can I really focus on it internally and really process that on my own rather than looking externally?
Right.
this person is doing this to me, more so taking like, what can I do to make this better?
Okay, that makes sense. I can see why that would help with like these feelings of injustice. Like I can affect these things in my life. It almost has like a component of like empowerment too, right? Like I have the ability to change X, Y, and Z.
Yeah, for sure. For sure. I think that this model kind of promotes, if injustice is something that we could look at, it provides a little bit more of autonomy in your circumstances.
Yeah.
So like I could be an agent of change in my situation.
Right.
Which is something that I thought would be particularly interesting and like for treatment outcomes for this model.
I feel like that's so important for children too, right? Because they already like feel like they don't have that much agency because they're children.
Sure.
Right.
And I think it's particularly important because, as we know, children struggle with emotion regulation, and maybe these like thoughts of injustice or maybe are leading to more pain catastrophizing or leading to other things. And maybe by addressing these thoughts of injustice, we can help like address certain things so that they don't have these onward spiraling effects and affecting overall sleep outcomes, or maybe alleviating some of their pain intensity. So
yeah, absolutely. Well, thank you so much for taking the time to talk to me.
Thank you, for sure.
Can you start out by introducing yourself?
So my name's Tracy Anastas. I'm a postdoctoral fellow at University of Washington and the Department of Family Medicine. And today I'm presenting on long COVID and pain, particularly looking at gender and racial disparities. So we know that musculoskeletal pain is really common during long COVID. And we also know there are well-known disparities for both gender and race in terms of pain in general, with women and people of color experiencing worse pain outcomes. So I looked at race and gender disparities within the context of long COVID and pain. So my study aims were first to look at the impact of patient gender and race on whether or not they had pain during long COVID. And then I looked at the impact of gender and race and pain on PROMIS 29 outcomes, which is a measure of physical and mental health. So I identified patients who had long COVID, and they completed a survey about whether or not they had musculoskeletal pain, and they filled out that PROMIS 29 measure. And I had a sample of over 500 participants, and I found that close to half had pain during long COVID. I don't know how many of these people had pain prior to COVID, so that is one issue with this study. I didn't find that men or women or white people or people of color were more likely to have pain, though it was kind of approaching for gender, and specifically women were trending towards having more pain, but it was not a significant difference. And I found for across all these outcomes of pain intensity, social functioning, anxiety, depression, fatigue, pain interference, physical function, and sleep, those who had pain had worse outcomes across the board. When I looked at the interaction between pain and gender, I did not find any significant interactions, which means that for those who had pain, they were equally worse for both men and women. For pain and race, I did find a significant interaction for anxiety and depression, such that both white people and people of color had worse anxiety and depression if they had pain, but it was even worse if they were a person of color. So kind of broad conclusions are musculoskeletal pain is really common during long COVID. It's associated with worse outcomes. And this data suggests that people of color have particularly worse mental health outcomes. So I'm hypothesizing that pain might be adding to social barriers like discrimination or lack of access to care that people of color face, adding to those worse mental health outcomes. And advocating for mental health treatment in treating long COVID for everybody, and particularly those who are people of color.
Here, another conference attendee asked whether the study participants still had long COVID symptoms or whether the symptoms had since resolved at the time of the study.
That's a good question, and kind of a limitation that I have on this. It's hard to tell, like, some people are saying, like, yeah, I'm not recovered, and other people are like, I'm pretty much recovered. So there is variation in, like, where people are at. They also got the survey at different times. So, like, they sent it out all at once, but someone could have had COVID, like, 6 months ago. versus like 8 months ago. But everybody's like, they're at least 3 months out. So they're all in like the long COVID phase.
Okay. Yeah, do you know how many, like what percentage of these patients are like actually in long COVID clinics to be treated for long COVID?
I don't.
Okay.
That's a good question though.
Yeah.
Because Nikki, who's my co-author, she was very involved in long COVID clinic at UW. And she's got some other trials going on, but this was just like a broader set of people. And you see, we had over 700 people, but a lot of people just didn't fill out the survey.
Right, and it's also there's such so I'm looking at the race breakdown, and there's still such a predominance of white participants, almost 80% of the participants were white. I had to
put people to color all together, which isn't my preferred approach.
Right, because you would rather look at differences between different groups, on a more nuanced basis, but
this is what I have for now.
That's what you have to work with.
Yeah.
Here, an attendee asked whether they tracked other symptoms of long COVID.
Yeah, they had a very long questionnaire. The other one that my colleagues been looking into is cognitive function.
Okay.
That's one. I think they have a measure on it, but I haven't looked at it yet.
That was great. Thank you. Can you start by introducing yourself?
Sure. My name is Shreela Palit. I am an assistant research scientist at Nemours Children's Health.
Excellent. And can you tell me a little bit about your research?
Sure. So this is some work that I did on my postdoc at the University of Florida with Dr. Emily Bartley. And we are interested in understanding mechanisms that contribute to chronic pelvic pain. So chronic pelvic pain is basically pain that affects your abdomen or pelvic region, and usually lasts for about 6 months or more. It causes a lot of concerns with being able to do activities you enjoy. It oftentimes also relates to people reporting other types of pain. So even though they have the pelvic pain, they may also have back pain or jaw pain, headaches, different things like that. So we were interested to see the relationship between having chronic pelvic pain and these what we call overlapping pain conditions. So we wanted to see, how many of these people were reporting, but also to try to understand the mechanisms behind this. We wanted to see, is there a component of the nervous system that's involved? The reason for that is a lot of the treatments for these are surgeries and kind of invasive things on the, outside. Can we fix something by doing some kind of surgery? But that may not really look at the whole picture, because we do see things like emotions and how we think about pain affecting it as well.
Yeah, absolutely.
So that's what we're kind of looking at in this study is, looking at the relationship between positive and negative emotions and whether this influences how, when people report a lot of different pain conditions, that relationship with those central nervous system mechanisms. So what we found in 197 individuals who self-identified as either male or female. We did not have any individuals who self-identified as any other sex or gender, and were predominantly white when they reported their race. That first off, we found that there were a relationship between people who had reported a greater number of these overlapping pain conditions, that they did show kind of this oversensitivity in the nervous system, and that when we looked at the relationship between those things and whether or not positive and negative emotions affected this, that it was really positive emotions that did kind of, affect the degree to which people with that relationship evidence this. So what I mean by that is individuals who had kind of reported low levels of positive emotion and positive affect were at a greater risk in a way of having a stronger connection between more reported overlapping pain conditions, greater nervous system reactivity, and but there were actually no differences with negative affect. So it was really kind of telling us that it may be more of a concern if people who are experiencing these conditions don't really experience a lot of positive emotion. And we may want to start looking at interventions that help boost positive emotion rather than just those surgeries and things like that from a behavioral standpoint, so that they can get back to the activities they enjoy, they can kind of live life life more meaningfully. And instead of just focusing on risk factors and what's wrong with the person, kind of looking at strengths and how do we build those strengths.
Right. Yeah. No, that makes a lot of sense. Sort of how do we emphasize these like positive aspects?
Yes.
How did you? I kind of missed how were you assaying central sensitization?
Yeah. So this was a survey-based study. So we were unfortunately not able to kind of bring people in and measure it, but we used what's called the central sensitization inventory, which has been used in many, many different studies. Highly reliable way of the individual self-reporting symptoms that are indicators for the central sensitization or oversensitivity of the nervous system.
Okay.
Yeah, so there were all questionnaires that we used to look at the positive and negative emotions, as well as the individual's own experience of different other pain conditions. So they already have pelvic pain, but what else do they experience on top of that?
Right. And so this like positive affect was like significantly associated with them having more of these other conditions, or like
basically it was, you can almost think of it as protecting someone from the impact that you can have with, like, let's say you have pelvic pain and you have back pain and you have, chronic fatigue syndrome or fibromyalgia, right?
Right.
So we already know that that's associated with this more activity in the nervous system. So we wanted to see, is there something that moderates or influences that relationship?
Yeah.
And that's where we found that it was positive affect, that people who had low levels of positive affect or emotion, they were the ones reporting the greater number of overlapping pain conditions that associated with that nervous system sensitivity. And so what that's telling us is that that's almost a risk factor for having that stronger relationship.
Okay, and so then do you think like different sort of models of therapy would be useful in these patients?
Yes. So right now, unfortunately, a lot of behavioral or psychological interventions focus on what's wrong with someone, rather than, like I was mentioning, the strengths and what they can already use to make kind of work through these things like gratitude, or there are some things called positive psychological interventions, and they focus on building those positive values and really helping someone work through those things, be resilient, rather than like, let's fix something's wrong with you. It's more like, hey, I know you're dealing with this, but how do we help you face it in a more productive way?
Yeah, that's really great research. Thank you so much for sharing it with me.
Yeah, thank you so much.
Thank you all once again for tuning in to this week's episode of In Plain English. Once again, our presenters were Ashley Bocanegra, Tracy Anastas, and Shreela Palit. You can find their posters on the website at inplainenglishpod.org, and you can find last week's episode there as well. Our music is by Sam Brunwasser. You can find more of his work at soundcloud.com/visualsnowbeats. As always, you can download the paper and read the transcriptions at inplainenglishpod.org, and make sure to follow us on Twitter, Facebook, and Instagram at Plain English Sci. That's PlainEnglishSci. Thanks again for listening, and we'll see you next time for another episode of In Plain English.